Chronic total occlusion PCI in action, study of challenges and solutions. So you'll be taking us through what they do inside the cath lab when you have these cases where you have chronic total occlusion of the coronary vessels. So I'll be handing over to Dr. Solomon to take over the presentation from here. So, Dr. Suli?
Okay, thank you, Dr. Ola, for your kind introduction. I'm waiting for I'm doing a request now, Ramatu, please, for the sharing my screen.
Just a minute, Dr. Suleiman, before you start, please, the link for the CNA will be in the chat room, and the link will also be sent to your email. So you should click the link and fill the form. It is important and compulsory for everybody to fill the link and to fill the form so that you can get your CME. So check your mail and do that within the next 24 hours because the link will expire after that time. So check the chats, check your mail, you will find the link there and you fill the form for you to get your CME. Thank you very much.
Ramatu, if you're there, please allow the share screen. Can you hear me? Can you see my screen now?
Yes, we can see your screen.
Okay. All right. So welcome everyone for our weekly conference at HIC. Today will be like, the interventional aspect of our work here at HIC. So we're talking about one of my favorite topics. I hope that I can make it easy for all of you because it is a very complex topic. It talks about one of the most complex intervention in coronaries, which is the CTO or chronic total occlusion. And we will be talking about a case that we did recently, just to know how we approach those kind of cases and also to know like when we need to intervene and how to intervene. So for this, this is a 66 years old male, hypertensive, diabetic. He had a history of non-STEMI 1 year ago, and he was treated at that time conservatively. He presented to our clinic with exertional angina that started to be at a shorter distances than he used to do before. So by definition, this became like unstable angina. He was on full anti-ischemic treatment, but still has exertional the angina, and he did an echo that showed 65% ejection fraction with no frank residual motion abnormalities. So in this case, we moved to another stress test or stress echo, which showed positive for stress-induced myocardial ischemia. At the mid and apical septal and anterior wall, they showed some hypokinesis. So the decision was to proceed with the angiogram. I will talk about the angiogram and then we will move to the actual film of the angioplasty itself, because we didn't do them both of them at the same time. We did the angiogram first, and that revealed total proximal LAD at trifurcation with the large diagonal branch and septal branch. As we know from the anatomy that we have like two systems, left system and right system. The left is starts with the left main stem artery, and then it bifurcates into LAD, and the circ to the back, and the LAD is like, yeah, it gives like diagonals and septal branches. So it was a kind of trifurcation that it gives the diagonal septal at the same level, and then it continues as LAD. And it receives a retrograde filling from the RCA, which is very, very important, because this what tells us like, yeah, how to look at the CTO, as we will show in a few seconds. There's a score that we assess those patients is called the JCTO score, or Japanese CTO score, and 12-3. And we will talk about it in the next slide, about like how to perform the JCTO score. The plan was to do a CTO angioplasty in another session, as we mentioned, and here we are talking about JCTO, and I will explain it on the film after a while, that when we have a CTO, which means chronic total occlusion, means that the vessel is 100% blocked. So how can we assess that? We have like different criteria that we have to think about the vessel when we look at it. One is the CTO segment, or the totally occluded segment, is tapered or blunt, because once it's blunt, definitely this add to the difficulty or technical difficulty in opening the vessel, and definitely it will be like, yeah, taking a score. If it's tapered, so it has a track, so it can be sometimes simple. The second thing is the presence of calcification along the CTO segment, because calcification will deflect our wires and also make it a little bit harder for regular or softer wires to pass through the vessel. So also the presence of calcification, it gives like a score of 1. No calcification is a 0. The actual angle that the CTO segment is on, sometimes there's a deflection or tortuosity in the CTO segment, which means that the artery is not running straight. So definitely more than 45 degrees, definitely this will add some more difficulty, and this will take 1. Also the occlusion length. So the CTO segment, if it is less than 20 millimeter in length, definitely that makes it easier than other CTO segment if it's more than 20 millimeter in length. Also, they added definitely also, if this is a retrial, it adds like a score of 1, because after the first trial, if we are trying to open a CTO and we fail and we need to do it again, sometimes it creates some kind of dissection at the CTO segment that heals with more fibrosis and make it a little bit more difficult to pass. There's another score now they are putting is the presence of bifurcation at the CTO segment, because the presence of bifurcation or trifurcation definitely will make the wire prefers the open pathway, which would be like always toward the side branch. And on the left side here, you can see that as long as the category of the CTO or the score is like 0, definitely this make it an easy CTO to be open. If 1, it's intermediate, 2 is difficult, 3 or more, that make it very difficult with like very low, or I will say like, yeah, low success rate. Here on this graph, it shows that, yeah, for a CTO, JCTO score of 0, the success rate is between like 90 to 95%. 1, it makes it like 70 to 80. 2 is like 50 to 40, and 3 or 4, it makes it like between 20 and 30, and sometimes 0. The most important thing in CTO is the planning. we have to understand, like, yeah, if we have a CTO case, that the planning is very important because we need to plan to succeed, not to plan to fail. So we have to understand the algorithm, that how can we tackle that vessel, how to think about it, what are the options that we have, and we will discuss later in another there's something called a CTO algorithm, that how to jump between different techniques to achieve a higher rate of success. Also, we need to monitor the patient to understand the pharmacology, the medications that we need to give to the patient, especially heparin, to assess the access site, because like most of the time we need two access sites, like one femoral and one radial, two femorals, two radials, according to the patient situation. Also the engagement, how to select a good guiding catheter that stays in place, doesn't like make the task very difficult by going back and forth and so on. This is also very important. Study the angiography again and again, because like, yeah, sometimes you may discover like an entry point that you didn't see before, and this is what I will show in our case today. Also determine the target lesion, because sometimes the CTO is not the target lesion, and there's another lesion that is affecting that vessel. So we have to understand which need to be tackled first. Wires are very important part of CTO PCI, because like, yeah, how to choose the wire, when to choose a stiff wire and a soft wire, how to cross like a septal or collateral, retrograde collateral. This is very important. Lesion preparation with different techniques, either like ballooning or rotablation or IVL or whatever. Stenting at the end, closure of the access sites, or sometimes like perforations, which is one of the complications that we can encounter in CTO cases. Physiology, also like to understand the physiology of the vessel, and sometimes we might need to do something called FFR or IFR to check if this lesion is critical enough or not. Imaging by using the IVUS and the OCT, and hemodynamic support in case of like, yeah, any kind of complication happens. So in our case here, we choose like two access site, which is something that I'm more comfortable using nowadays because of less complication, which is distal radial or snuff box, as some of the operators can identify. It is like, yeah, it's not the regular radial artery. It's the distal portion of the radial that goes on the dorsum of the hands. Actually, we found that there's less spasm, less bleeding tendency, better compression, and more comfortable to the patient and to the operator too. So it was a good access, and we do it ultrasound guided. Here we are. This is the beginning. This is the right. This is a JR catheter. It's a right coronary catheter that we put in the right side, and this is we are trying to pass the other guiding catheter to the left. It was a little bit challenging because of some tortuosity in the subclavian artery and the right one. So, but it went down, and then we started to do our angiogram. Here is there's a very useful tip in bilateral injection, because this is very important, so you can identify where is the lesion and how long is the lesion. As you can see here, that we inject first in the RCA till the LAD becomes like, yeah, visible here, if you can see. And then we can assume that the occlusion, the site of occlusion is like starts at some point here. It's an ambiguous gap, as we can appreciate. and the CTO segment is long, and we can see some kind of calcification running over the vessel. So by definition, it is like there's a calcification longer than 20 millimeter in length, and it is ambiguous, and the entry point is unclear. Again, from another view, this is what's called the spider view, just to identify where is the entry point. Actually, still not so well defined. So we took like a focused angiography here, and we can see a very little knob here that can be the entry point. So we started to try to pass out soft wire first, what's called the workhorse wire, which was pilot 50. And this is what would be like familiar to like intervention cardiologists, something to navigate through, but it went through a septal, the first septal. This is the first first bifurcation, as we can say, at the CTO segment. Here, one of the rules or the things that we should be aware how to use, and always like try to use in CTO PCI, is the use of something called microcatheter. Microcatheter is a very thin tube that goes like even through the very small channels and so on, and we can inject dye through it. So here, when we were unsure where the wire went through, so we can inject some dye, and we can see that we were in a very large the septal branch before the CTO segment. Here we tried with another wire just to tackle the thing. At this point, that was a stiffer wire, which is a wire called Gaia 2 wire. It is a very stiff wire that can navigate through calcification, but unfortunately here, as we can see, it was not aligned with the vessel itself. So most probably it went through a false track. So we had to pull it back and try to do some kind of maneuvering till we get through the channel. Still, we were not like very sure where the wire is, and we had to do another run of the microcatheter injection. And here it is a little bit much better shown that the LED is somewhere between the big diagonal branch in the upper part of the image and that septal branch that goes down. So our track should be between those two vessels. Here we're trying through the spider, because now we can see that there's like some kind of a channel opened after we tried the first time, and to the side of the diagonal. So the wire now is going into diagonal, and there's on the left side there's a big septal now is open, and there's a track between both branches. Here we're trying to navigate to start to go somewhere, and we kept like tracking, and now you can see that the wire is in the between both branches, the diagonal in upward and the septal downward. And this this is we assume that this would be the right track. So again, we pushed our microcatheter in just to give more support to the wire, and you can see after we pushed it a little bit, the wire start to go. It was very difficult actually, especially that there was a lot of calcification that prevent the wire to go through easily, but it start to go bit by bit, and until we start to see that we can navigate through the calcification to the mid segment of the vessel. Here you can see this is another tip injection from the microcatheter that we were lucky. Actually, I was trying to do a technique is called hydraulic dissection reentry. Like when we are in a CTO segment, sometimes it's very difficult to get through from true to true human. So sometimes we inject purposely some small amount of dye to create kind of dissection in that segment. So that would make a better way to navigate through the CTO segment until we get to the true lumen. But here we were actually lucky because once we injected in the CTO segment, actually it opened directly into the true lumen, and it made our life much more easier, because what was expected is to cause some dissection, and we still cannot go to the true lumen, but actually it went through. So the next, we just kept the microcatheter in place. We used like a softer wire because we cannot like go with the stiff wire all along the vessel, because it can dissect the vessel easily. So this is a PT2 wire that, as you can see here, it went very easily to the distal side of the vessel. Again, just to make sure that we didn't go through a dissection plan or something. So we just like pushed the microcatheter and had a distal tip injection that confirmed that we are in the true lumen. So now we can put back our wire, and then we start to balloon. Actually, the ballooning also was a little bit difficult because of the calcification, and we were trying to avoid like using like root ablation in this case. But yeah, we were ready. If there's any need for a root ablation, definitely we'll go for it. Still, the vessel didn't open completely from the antegrade injection, so we did some more ballooning, and this is after ballooning. You can appreciate like, yeah, the extension of the disease. This is a bigger balloon with a longer and bigger balloon at this point. And now we can see that, the vessel is there. So the next thing, after good preparation of the lesion, and so we need start to stent, but I prefer to go for a bigger balloon, because like if we stent a calcific segment without good preparation, sometimes it can lead to unexpanded stent, which is a catastrophic result, and it needs like some special equipment that we don't have. So the good preparation of the lesion to make sure that the stent goes freely and open completely, this is very, very important. Okay, this is the first stent here. We after we put the stent inside, we couldn't see the distal end from antegrade, so we had to make a retrograde injection. So we injected in the right, so to see the distal end. And here again, we did another round, and then we inflated the first stent. Unfortunately, there was a small distal dissection to the distal end of the stent, but we said that, yeah, let us look at it in different views and treat the proximal segment first, and then we can recheck on that later. This is the next. This is the next stent proximally. We put it at the end. We open. And then this is post-dilatation. So we did the angiogram. After that, we can see two things in this view. One is the distal stent edge dissection still there, and it looks like, yeah, it can result in re-occlusion of the vessel. So we have to deal with it. And also, there was some kind of slow flow in the first diagonal that we were in, which made us suspecting something, that we took another view. So if you can see that there's a filling defect at the mouth of the big diagonal here, which was a clot. Actually, we double checked on the ECT at that point. It was like, yeah, like almost like 275. It should be like between 300 and 350. in case of retrograde intervention. But, okay, so we gave an extra dose of heparin and we started to balloon. We started like, yeah, we said like, yeah, we need to treat the first the distal dissection. We put another small stent there, and then we inflated. Okay, now the dissection has like, yeah, disappeared, but this is still the filling defect in the ostium of the diagonal is still there. So we passed another wire through the proximal stent, and then we put like a small balloon there just to make sure. And actually after that, that clot defragmented, and the flow, as you can see, TMA3 flow and everything went very well. So the patient definitely, yeah, finished. He was. It was a long procedure. Actually, it took around like 3 hours with almost 1.5 gray of radiation. The patient was definitely, because of the diagonal thrombus that happened, and then we managed to open and so on. He had some chest pain after that. That vanished after like, yeah, almost an hour after the procedure, and the second day he was totally fine. So here we want to talk like, yeah, fast about like how to tackle like CTO, like CTO PCI. First, we have, as we said, to identify where's the lesion exactly, where's the cap, the proximal cap and the distal cap. The proximal cap is the area that the CTO starts, and the distal cap is the area that the CTO ends. So if we can see that there's a proximal cap ambiguity, so we may think about other techniques like retrograde approach or dissection reentry or IVUS guided CTO, which is called move the cap technique, because we need to see where the wire will puncture, because the ambiguous cap will not be able to find out where's the appropriate site of entry to the vessel. So we have to identify it by either the IVUS or OCT, but definitely it's better to use the IVUS in those situations, because IVUS gives a live image for longer time. And then, so if there's no proximal cap ambiguity, we have to take a look on the distal vessel quality. If it's poor, you still may think about the retrograde. Actually, in our case today, the distal vessel was of a good caliber, as we can appreciate from the retrograde injection from the RCA. Also, we need to identify which way to go. Either anti-grade wiring. So we have two techniques. One is the parallel wire technique, which is like put in a wire, created if you feel that you're not in the true lumen, so you leave the wire there and you take another wire, try to navigate beside the first wire, but not in the same direction, because we know already that this is the wrong direction, and we try to find another direction until we managed. There is a lot of techniques, the seesaw technique, the stick and swab, all those things can be used at this point. And we have other cases that we can show in the common interventional session about like how to use those different techniques. The other technique is the anti-grade dissection reentry, which is as if you have a blocked road, so you just like move or walk on the sidewalk until you finish that blocked road, and then you go back to the right track. This is so it doesn't go through the CTO body itself; it goes beside it through the subintimal track. There's a very dedicated devices with something called stingray balloon, and also like we can use the dual lumen microcatheters to go like in subintimal and try to puncture the true lumen after the CTO segment. It needs like, yeah, a lot of skills and many maneuvers, but yeah, it is an approved approach to tackle those cases. Also, the retrograde approach, it has a lot of techniques, the cart, the reverse cart, the star technique, the base, a lot of techniques that can be used. We will also be discussing this in later presentations. Here, the issue of like explaining all those techniques is to find what could be the best to begin with, and then you have the ability to switch from one technique to another, because at the end we will not be doing the same thing over and over, and we expect success every time. We have to have the maneuvering around the CTO segment, because sometimes if integrate is not working, we have to go retrograde. Sometimes retrograde is not working, we have to go to integrate. Sometimes both are not working, we have to do like integrate, dissection, or entry. So we have to have like to get the skills for all the options, and so to increase the success rate in case of a CTO PCI. Sometimes it's very difficult to cross. So what we can do is something called an investment procedure. Investment means that at least if we did some kind of success in managing to cross part of the legion, or we did some kind of dissections and we don't want to lose the vessel in upcoming procedure, so we can like stent that vessel up to the CTO segment or something, or just like, yeah, do a drug-eluting balloon or something, just to keep it as it is till a next trial to be done, which is called an investment procedure. If everything fails, we should know when to stop. This is the most important message here. Why we need to know when to stop? Because like, yeah, still CTO is a coronary intervention that has a lot of complications, but the rate of complications in CTO PCI is way higher than the regular intervention. There are cardiac and non-cardiac complications. If we talk about the cardiac and the coronaries, definitely dissection, which I don't say that this is all the time a complication, because sometimes we intend to do kind of dissection to reach to the true lumen, but sometimes that kind of dissection is extensive and can cause like a very bad outcome. And also sometimes we can dissect the donor vessel, which is like, yeah, if we have a CTO in the LAD and the RCA is the donor vessel, put in the catheter, a catheter in the RCA can sometimes cause a dissection that we don't see. So we have always, before even like finishing our case, to check on the RCA side or the other donor vessel side to make sure that there's no complication there. Also thrombosis, like what happened in our case, but thank God we managed to defragment that clot. Embolization, either a thrombus in the guiding catheter, or rupturing a plaque, or injecting air, which is sometimes like very common, especially in very prolonged cases. Side branch occlusion, like what happened in our case, it was not total occlusion, but yeah, it showed some kind of decreased flow to the side branch, which was managed at the end. And spasm, it's very common to happen, especially when you manipulate a lot inside of the vessel. This can cause definitely irritation to the vessels and causing a spasm. Pseudo lesions, also especially when you use stiff wires, it sometimes make the vessel, especially in tortuous vessels, making them straight and causing something called accordion effect or pseudo lesion. Sometimes definitely we can lose some equipment, especially wires. If it goes through a calcific lesion or something, the calcium can entrap the tip of the wire, and sometimes it can we can lose the wire or a balloon or a stent inside of the vessel, and this definitely can be a very, very challenging situation. Intramural hematoma, it's a very common complication, especially in dissection reentry, because once you open the subintimal space, the blood still keep flowing through the coronary, and this this blood is flowing through the true lumen and the false lumen at the same time. But if the false lumen start to collect more bloods because of the true lumen is collapsing, definitely it will make the situation very difficult to re-enter to the right track. Aortic dissection, this is also can happen, especially in osteal lesions. And also when we are doing some kind of traction on our microcatheters and wires. And that's why the microcatheter is very important, because it makes a solved in interaction between the guiding and the vessel, and doesn't expose the wire always to the vessel, so it doesn't make a hard friction with the vessel. Other complication, which I will not say common, but it is very, very serious, which is the perforation. We are using very stiff wires, actually. If we're talking about Gaia wires, Confianza or Conquest Pro, Hornet, Pilot 200, Miracle, like, 9. Those are very heavy wires that sometimes can go straight into, like, through the vessel and outside. And this definitely, when we are trying to pass our wires and equipment and tools and so on, especially after ballooning, you can see a very ugly perforation, and this can be lethal sometimes. In the non-coronary complications, very common to see: hypotension, myocardial infarction, arrhythmias, sometimes tamponade in case of perforation. And non-cardiac, definitely the vascular access complication. And that's why, definitely most of the time we may need to use like bigger catheters, like 7 French or 8 French, which needs like a bigger access site, like femoral artery. We're trying to do most of the cases like through 6 French, so we are able to do it like through radial, because the access site complications will be way less than femoral, especially in using like extra dosages of heparin and so. But this is one of the things that you can see frequently, especially in femoral access, that you can see hematomas, retroperitoneal hematoma, and sometimes like a lot of like thrombosis and so. Thromboembolic complications, strokes and peripheral thromboembolism, still can happen. Contrast-related complications is very important to assess the amount of contrast, especially that you have to calculate the GFR before going to the cath lab, and try not to use triple times the GFR. So if the GFR is 60, you are not supposed to be using like more than 180 to 200 cc of contrast. If it's like 90, you still can do more, but if it's less, you have to be very cautious, because this is a very long procedure and a complicated procedure. You may need to use a lot of contrast. Actually, in this case, like, we used almost 220 cc of contrast, which was like within average for this patient. But calculating the amount of contrast before even going on to do the CTO PCI is very important. Also, radiation injury it's very common, and actually the radiation injury can happen to the patient and even the interventionist, because those procedures can be very long. Sometimes it can be up to 5-6 hours, and you may need some magnification using a lot of caudals and views and so. So the radiation injury is very common in those cases. So you have to be cautious. Make sure that the table is low and the tower is like very close to the patient, and you ask the patient if he feels any kind of burning sensation, especially in the back. Again, the CTO PCI, we have to admit this is a very complex procedure that might need a lot of tools, which is like, we have to understand that this is very expensive procedure, because in one patient. In our patient, we used almost like 6 wires, 3 or 4 balloons, something like that, 3 stents, and this is like, yeah, those are the average. Sometimes we might need to use like 2 or 3 microcatheters, and 1 microcatheter we used in this patient. But sometimes we need, if we go retrograde, we might need to use like 2 or 3 microcatheters, guide catheter extensions, short and long wires, special balloons, CTO balloons. Sometimes in case of perforations or something, you need graft stents or coils to close like any kind of perforation. So most of the time you need to be very well prepared for complications, even for the CTO itself, because we don't know when we will go to the true human, and we don't know when we may fail. So we have to be prepared from the beginning. This is almost the last slide that is talking about like the 7 global principles that we need to for CTO PCI. The first one is to improve symptoms. Actually, we have to understand if this CTO is functional or not. In our case, like, yeah, we did the echo. It didn't show like wristernal motion abnormalities, but we did the stress echo, and it showed very clear evidence that this CTO is functional. Also, the size of the vessel is very important. The complaint of the patient is very important, because some other times, if the patient doesn't complain of chest pain, you don't see a clear sign of ischemia on the ECG or the echo or the stress echo. So the feasibility of opening that CTO, it can be like debatable. So as long as we have the objective evidence that this patient like is suffering because of that CTO, so definitely this is very important to open. Also, dual angiography, like I can see like 80% of the cases is a must, because like without the dual injection, unless if there's like ipsilateral retrograde collateral, like from the circ to the LAD, or from LAD to circ, or something, or sometimes the RCA came in bridging collaterals, or collaterals that coming back from the PDA to the proximal RCA. At those point, 80% of cases it needs dual injection, and to be very meticulous about like how to identify where is the CTO segment, how long it is, and where is the proximal cap and the distal cap. Use of microcatheter for guide wire support is almost always needed, unless if there's like a CTO JCTO score of 0 to 2. You may still can use the wire only, sometimes with the support of a balloon, if you think that this is an easy lesion to cross. But otherwise, most of the time you need a microcatheter, because mostly you will need to change the wires many times, so you have to be prepared for that. We have that CTO crossing strategies, the 4 CTO integrate wire escalation, which means that you go with a soft wire, and then you escalate to a tapered wire, and then you may escalate to a stiff wire, and so. And this anti-grade dissection reentry, which is, as I'm saying, we bypass the CTO segment and we redirect to the true human. Retrograde wire escalation is and retrograde dissection reentry, those are the same principles. A change increases the likelihood of success when we switch from, if the anti-grade dissection, anti-grade wire escalation is not working, so we switch to retrograde, or we switch to anti-grade dissection reentry, and vice versa. This will increase the success rate, but insisting on one technique, most of the time it like make a higher rate of failure. CTO PCI should be done with experienced and well-equipped centers. This is a must, but at the end, we are in developing countries. We may encounter a lot of challenges with low resources and so. To say that you have to be well equipped, like one of the big CTO centers in Japan or in the States or in Italy or something, it will be like something like very luxurious, and most of the patients will not be able to pay for all those things. But at the end, we have to try our best to provide our patients with the best care they can. Especially most of our patients, they will not be able to afford like traveling or going to some of those centers, and we don't definitely we have to have that kind of skill locally so we can help those patients, because sometimes it takes so much time to for like those patients to find out how to be treated, and this can affect their either quality of life or their life itself. Stent deployment should be optimized because still we need to optimize our results. Putting a stent in a CTO segment, sometimes it's very challenging, especially if it's undersized vessel because of long-standing CTO. So we have to maximize the stent size as much as we can. Sometimes it comes with a challenge like what we have had today in our case with that distal edge dissection, but it is expected and we can deal with it, no problem. And we have to optimize the result by making sure that the stent is well opposed to the walls and well deployed. This is we are talking here about the gap. Definitely, we still having challenges, especially in developing countries, to achieve a high success rate as the developed countries. But we can see now, as compared to in the past, that the success rate now is hitting the 80% and 90% in most of the places, especially with people like having the proper skills to deal with. And also those kind of like cases you need to discuss with your colleagues, try to find new techniques, watch a lot of videos. And so I have to thank Dr. Manos Berakis. He is the former president of Sky. That I brought a lot of useful slides today for this presentation. And actually, the way that we are doing things definitely is very, very different from the way that we used to do things in 10 years ago. So we hope that in the coming time that we can train ourselves better, train our colleagues and fellows, so they can have that skill. Because even when you have the good skill in CTO, definitely the regular intervention will be very easy. Here also another fundamentals why we open the CTO, because it's functional. And how, as we said, dual injection, careful review of the angiogram, safety wire in the donor vessel, microcatheter use algorithm, change, optimize. And the last, I don't want to be scary, but you have to be aware of the risk. I will not say to be afraid, but to be always careful and suspicious about what you did. So if you're on false track, don't go further. If you feel that you might got a perforation, don't push more. Just like every step you do, you just recheck and recheck and recheck until you make sure that you did it safely for yourself and for the patient. And thank you.
Thank you very much, Dr. Suleiman, for the exhaustive and wonderful presentation. You've actually tried to make it simple for us non-interventional cardiology to be able to at least have a basic understanding of what you are talking about. So I think there should be questions for you, and let me start by asking some that I have here. Number one, I want to ask looking at the technicality and how difficult this can be. I know there are some times when you go in, you might not be successful at the first attempt, and you might have to take the patient back. Is there a limit to the number of times you can try to open up a city, or you keep trying until you find a way?
There's no definite numbers, definitely. But the more numbers you go to try to open the same CTO, definitely it makes it more difficult. Because if you are truly trying to open the CTO, you will create a lot of channels and sometimes dissection that can end up with like complete closure of the vessel, even like more proximal than what you started with. And it may make it difficult for you as an operator or for another colleague if the patient goes to another center or something. It may be more difficult for them to try to open. But because it's a dynamic environment, and every day we have a new skill and a new technique and a new thing to do. Actually, I tried that the hydraulic dissection reentry, which is derived from something old, a little bit, it's called Carlino technique, which is like try to induce a big dissection. So that dissection can give you like layers that you can go through to the true lumen. But now it's more controlled because the old technique was very aggressive. Now it's way more controlled, and we can inject like as 0.5 to 1 milliliter of contrast. So we can create a very controlled dissection, and then we go through. Actually, it worked. So most of the time, it is a challenge that you keep thinking about a way to how to solve. And that's what made the success rate, it went like maybe from 30-40% to 80-90% nowadays. And even like in some centers more, because we don't accept failure as an answer. You understand? There's a way or another to open that vessel. Okay? Definitely there is a way better than another way, but at the end, the opening true to true is not a big challenge nowadays as before.
Okay, thank you very much. Then my second question is the post angioplasty management. Are they patients with CTO? Are we going to manage them the same way we manage others with non-CTO occlusion, just the dual antiplatelets, or do we need to give them anticoagulants with the dual antiplatelet, or we do the same thing we do for other patients for them?
Yeah, no, the same thing exactly, but maybe we go like for the newer antiplatelet agents like prasugrel or ticagrelor. I like them more nowadays. But the regular thing, sometimes it's still off-label. I can see like some little literatures talking about it, like using anticoagulation in case of like thrombosis or something like that. Still needs like more studies to settle down. But yeah, some people they can use like some small dose of anticoagulation in case of like side branch thrombosis or instant thrombosis or something to see. We saw some patients did that, and actually it went very well. The total clearance of any residual clots, which is a good thing, but still it's a very small scale and it's individual cases. We need like higher, like much bigger population to say that this is a safe practice.
Okay, thank you. I saw a question in the chat block box, someone asking about the idea of the costs. I don't know if you have an idea of how much it costs in Jamaica.
There's no fixed cost. The problem is the more the tools you use, the more the cost you will get. Because the issue is sometimes like a CTO that you think that this will be like a very high cost and so on, and it can be done but with one or two wires. And sometimes a simple CTO that you may need 10 wires and 3, 4 balloons, 2, 3 microcatheters, extension guiding, 2 guiding catheters, a lot of things that can, if you use IVUS, so it can be easily millions of dollars in no time.
Okay.
So that's why I'm talking about the feasibility. You have to make sure that this vessel is feasible to open, to have the objective evidence that this CTO is functional, and it's something that yeah, it will benefit the patient. Actually, I was
The
very happy with
patients.
when I saw the patient in his follow-up after a week, that he said, I'm completely different now. My breathing and my chest is totally different, and so, which is like very good result. Uh, but as I'm saying, it comes at a cost, at a very high cost. Sometimes it's like, yeah, an open heart surgery or even more.
That's great. I don't know if there are any comments from the people on the call. I think I can see Dr. Elliot on the call. I don't know if he has any comments or anything to say about the presentation. I don't know. And if
Definitely.
anyone has
Yeah,
any
Dr. Elliot,
comment or
yeah.
question.
You're mute, Dr. Elliot, yeah. So,
Hi, Dr. Solomon.
yes, Dr. Elliot. Hi.
Hey, congrats on that case. Very well done.
Welcome.
Yeah, doing CTOs can be quite challenging. I'm not an expert on them. I've done a few, some successful, others I would leave to people like you, definitely.
It's a pleasure to do it like together.
Yeah, it would be great to do a case like together. We have a kind of
Yeah, sure.
spoken a little bit about it, but
Sure.
and yes, unfortunately, the cost can really be the limiting factor in some of these cases. But congrats on that case. It was quite interesting. And you're right, there are more tools coming out and more toys to play with, so to speak. But you did a great job. I just wanted to say congrats on that. And
Thank you.
you know, as you said, it's been able to do more and more of these kind of cases here in Jamaica instead of patients having, well, some can't get to travel and or to even have to go abroad away from family and friends to get it done. But the fact we can get some of these done in Jamaica makes a difference a lot of times just to the psyche of the patient. So congrats and great case.
You're welcome. Yeah, thanks a lot, Dr. Elliot. Definitely what you mentioned is the cost. But I will tell you something. If our patients, they have the access to travel, but they don't have insurance over there, this kind of cases will be done like a triple or 4 times the cost that they can have it here in Jamaica, because there's a lot of factors overseas, like you can understand, and especially if the patient is paying out of pocket, this will be like way more expensive than doing it here. Still, I do believe that the cost in Jamaica here will be way less than overseas, because like I heard like some crazy numbers, like in the States, like up to 100 and 150,000 US, which definitely will not be the case here. But as we say, it is challenging case. Definitely, you need to ensure the success rate at the max, because and also you have to talk with the patient about there's a success rate for such procedures, and there's a failure rate, and we have to look at it from this point of view, and we may need to try to redo it again in another time. Those are things that we have to be very clear in discussion with the patient, so we can make sure that our patient, they understand the risk and the benefits, and also they understand that the cost will be very different from, like, yeah, going overseas, the travel there and doing it out of pocket. Definitely it will be like very challenging. In case of insurance, this is up to the patient, because the CTO, still CTO, means chronic. unless the patient is unstable to like having chest pains every now and then and unstable. So definitely it's up to them. But for now, I can see that we have the potential to do it here in Jamaica. We have wonderful colleagues here, Dr. Elliott, and other our colleagues at HUI, Dr. Gordon, Dr. Redwood, and Dr. Crooks, and they also Dr. Rivera. So we have a lot of names now, in Jamaica that definitely can adopt like some new ways of getting this done here in Jamaica. So I hope in the future that we have that kind of collaboration and we assist each other to get like the best to our patients.
And I would just want to emphasize a point you made about the cost. You're right. If you go out to the state and you don't have insurance, the cost is much more. And a lot of people don't realize that. They hear the cost here and they go, wow. But if they were to go abroad without insurance, it is definitely much more expensive.
Thank you very much. I think that's part of the education we have to be giving to our patients, that going abroad sometimes costs more. And apart from that, the risk associated with flying in this condition also makes the outcome very, very poor. So thank you very much. I want to thank Dr.
And also, Dr. Ola, I would like to add, like, yeah, we have to have that healthy jealousy, you know, why we send our patients abroad. So we need like, yeah, to push ourselves more. I will not say jealousy,
yes.
but I would say like, yeah, to push ourselves more. Sometimes it's very challenging, definitely. You need to understand the challenges, and we pray to God that, yeah, we can do our best and we benefit our patients as well.
Yeah, so we'll keep trying and we'll keep pushing. Thank you very much, Dr. Suleiman. It's been a wonderful presentation. And I want to appreciate Dr. Elliott too for his contribution, and I appreciate everybody for joining the conference today. So next week, Thursday, will be another conference. We'll share the topic early in the week. And let me remind us again, the link for the CNE is in the chat box and also in your mail. So you should not forget to follow the link and fill the form for you to get your CNE. And as I was told that the link will only be active for about 24 hours. So let's do that so that our CNE can be sent to our email. So thank you very much for joining us. So we'll see you next week. Enjoy your Easter and have a good time.
Okay. Happy Easter for everyone. Okay.